actually, how do you to deliver sort of pearls of wisdom in an evidence-free zone? And I say that because, we know that for the people that we care for in residential care and frail elderly community, they're not in the studies from which we try and draw the evidence. So it took me quite a while, but I tried to sort of figure out what questions we might have, and could I find at least something that's addressing it, even if it's not a randomized controlled trial, that kind of approach. So let's see how this works. I don't have any commercial interest. I'm going to go fairly quickly. You can access the slides. I'm just going to pull key points out. But this one is from, and I put references in the absence of evidence and absence of guidelines, how do you give recommendations? And recommendations are actually silent in relation to our population by and large, and defer the decisions to us as either individual medical practitioners or people working in care homes. So that kind of prefaces that we have to figure out, given what there is available, how we can message this. And my approach is to look at what's available as evidence for the general population. Because if it's not working for them, it may well not work for the people that we are trying to look at. And then in the stable elderly, is there something that's evidence-based? And then see how we can apply it to our population. Now this approach comes from Fraser, and as Dr. Becker mentioned, there's a provincial polypharmacy risk reduction initiative, and we work with a variety of health authorities, but particularly the divisions of family practice and the new residential care initiatives. And this approach, I think we could use to think about any particular medication or groups of medications. And as you can see, it really starts from looking at the person, their frailty, what they have as far as diseases, what we might expect as they age in the care home, and then from that have goals of care discussions. Because as we've gone around the province doing this kind of work, the people that are experienced and feel much more comfortable in doing this, and that includes nursing and pharmacy, have actually thought about goals of care and had goals of care discussions with particularly families in residential care, so that the families understand that the people are there to live the balance of their life, and we're trying to do a focus on making sure they're comfortable, the symptoms are controlled, that sort of thing. And so really, if you have that discussion first, then the actual discussion about medications is much, much easier to have rather than diving into medications. And of course, doing assessments, looking at the benefit and risk of drugs, I'll give some of that, and developing a plan, and then having the discussion with resident and family after. So this is an approach that carries through for any kind of look at medications, but it also carries through for our clinical approach as well. So this is how it's centered. So when you're looking at reviewing medications, as I said, goals of care, treatment targets, we'll be discussing that with diabetes, blood pressure, etc., and looking at the information that's there on benefit and harm. There's a number of ways to profile that, and I'll do that very quickly. Adverse drug events, and then remaining life expectancy. So I'm going to go through some of those areas very quickly, but in relation to statins. So, I think we need to recognize, and we probably do, that if you're working with a frail old person, it's really not all that much different from the point of view of cardiovascular risk reduction, as best you can do, and it's not all about drugs. We still look at diet, we still try and look at exercise, of course smoking, so those things still apply as we're trying to look at targeting blood pressure, cholesterol control, and particularly diabetes as well as a risk factor, so these risk factors. So if you're thinking about statins, you're not really just thinking about statins, because we're using statins for cardiovascular risk reduction. So think about it in that context. And I guess I'm kind of a contextual person, but when I'm actually approaching and seeing a resident or a patient, I still have this in my mind, what's happening with them around these areas as well. So it's not just about drugs. And so we actually, for cardiovascular, we think of people at risk. And have they had an event before? Did they not have an event? Do they have diabetes? Do they have all these risk factors? But for cholesterol itself, there's a risk paradox. And there is some thinking around this, not definitively proven, that if you lower the cholesterol too much in older people, especially frail old people, that they're going to get negative outcomes from that. So what's the balance that we're trying to achieve? It might not be the lowest cholesterol that you can try and get at, which is what the guidelines are promoting now. Because if we actually go that route, just like really low blood pressures, really low blood sugars, we're going to be creating problems with these frail old people, because cholesterol is involved in a lot of the body processes and frail old people are so susceptible to any changes. So if we lower the cholesterol too much, then we're going to have problems that way. So that's one of the paradoxes we're working with. So this is, I just kind of drew this out for the talk, and I'm thinking as we try and look at the population that we're working with and try and figure out, it's pretty heterogeneous, even within residential care. And so I thought, well, maybe this is a way of thinking and grouping according to goals of care and clinical factors. So there could be people that say, well, I'm really worried about a stroke or having a heart attack more than symptom control. And of course, they'll say they want both. But if they've had no previous cardiovascular event, then how do you actually review the evidence? But they may want to stay on a statin, for example, even if the evidence is not strong for use in that particular person. And I've got some cases around this. And so that might be someone who's not had an event or someone who's had an event before. So this is the way you might break it down as you're trying to actually think about having these discussions. And I'll go through this in the cases later. But there are people, and I think this is more common, who say, I don't want to take a lot of pills. Certainly I don't want to have a stroke or MI, but really I want to make sure my symptoms are controlled. And if drugs are causing problems, then I'd rather not be on the drug. And these people may have not had an event before, so that makes it a little bit easier. This is kind of the easiest scenario to work with. If they're really concerned more about what the drug negative impacts and they have not had an event, then we'll probably feel more comfortable taking them off a statin. And there are some people that maybe had an event, and so then we have to think about, well, when was the event, how severe was it, all that kind of thing. So as we go through, and later on I go through the cases, this might actually help as you're approaching patients to try and sort of piece it out as to how you might approach it with any particular individual resident if you can place them in this context.
I don't quite understand the first column. Why the greater signs?
Well, it's because what they would like for their goal is control of, they would rather, not have a stroke or MI, and if they're going to have some side effects from a drug, they're willing to put that up with that, because they're so concerned about having a stroke or a heart attack. So that's the way and some people will say, as you talked about the drugs and the possible side effects, they say, well, my granddaughter's getting married in a year, and I want to make sure I'm around for that. They're not going to talk about survival in those words, but they'll say that. And so you really have to take that into account. Other people will say, I'm really tired of taking drugs, and I really don't want the drug side effects, and they don't have any kind of goal around sort of staying around for a period of time for something specific. And so that would be the other type of category of people. So that for them, symptom control is more important. But as you get at the goals of care and try and tease that out, and what's really important to people, then this is the kind of information that you can get.
So symptom control is also sort of comfort,
Well, very much comfort.
I don't like taking pills, that's a symptom.
Or, I'm just using that as sort of a grab bag of that.
Yeah.
Or I don't want side effects for the medications.
Okay.
I only use medications that treat my direct symptoms. I'm not worried about the prevention drugs, that kind of thing. They won't say it that way, but as you talk with people about their goals of care, you kind of start to get their sense of it, and the families as well, type of thing. And this is what you need to have those discussions and piece it out. Otherwise, how can you approach the medications, especially the preventative medications? Because you won't have a sense of really what they want. So some comments about statins and aging. And of course, as I said, there's not really a lot of evidence over the age of 80, at least not from randomized controlled trials. I've often wondered, because I've done so many, sort of consults in residential care, follow people in the community, a large number of people that get into residential care, particularly the ones with Alzheimer's disease, and they don't have a lot of cardiovascular comorbidities. Are they survivors? Are they different than the people that, perhaps younger that have had cardiovascular issues and may have died of them, or certainly we have people in care homes who've had strokes and they're there because of that, and maybe they have a dementia associated, et cetera. I'm not talking about those people. I'm talking about, all those, the people with whose main problem is dementia. And they actually have not either obviously died or else have not been impaired with cardiovascular disease that's caused disability. And I think that's a group of survivors. And so the reason I put that in is that then I asked myself, well, do statins affect long-term mortality in patients hospitalized with coronary artery disease? And these were people that 50% had acute MIs and were put on statins. Now, this is not a strong study, but as I say, there's not much in the way of studies. But statins didn't actually increase, if they compared the groups, didn't actually contribute to a gain in long-term survival using statins. So in older people, we don't know whether they're, in this type of people, whether they're actually going to be effective in the same way that they are for younger people. Also, I found a study that looked at the actual plaques, and this is sort of the way the arteries have the plaques in them, that have less lipid in them and they're thicker, so they actually don't break down in the same way. So some people are thinking that the people that actually get to this type of age might actually not be the ones that are going to have the higher risk of strokes. Again, I'm trying to piece it together because there's very little evidence about this kind of thing, and nothing's in one place. And declining importance of low-density lipoprotein. So the cholesterol issue is less important in older people as far as a risk factor. And also, of course, people have so many other reasons why they would die, so that the length of time it takes for a statin to work, or if you're taking a statin off, there's lots of other reasons why they're going to die because of all the other conditions. So those are the few of the things I found to say, is this population different? And are we over-concerned about statins because we're trying to think of, people that are younger and who the statins might be more effective for. So I found that information. So what about strokes? Because really I geared a lot of this to strokes because I've heard many times as we've gone around the province is that one of the reluctance upon everybody, patients if you're talking to that stage, family and physicians and others, is if I take them off a statin, are they going to get a stroke? And so I kind of geared it around to that to see if I could try to find some answer to that. And some people are talking about statins have an anti-inflammatory effect, and that's really early, happens in the first couple of weeks when you start the drugs. So if I take them off, is that going to reactivate, and is that going to actually contribute to an early stroke? Is there evidence of that? One of the issues in the studies is not all strokes are related to the lipids, and the biggest impact of statins are on the large vessel ischemic strokes. But the studies tend to group all the strokes, and they don't kind of tease it out. So you don't know whether, if you broke it out, are the statins more effective for this? And we should be actually targeting that. So we don't know that. Another piece of information is that if someone has a stroke, 20% of the people who have a stroke will die. This is in general. And recurrence over 5 years is about 20%. So if you stick to that 20%, 8% live, but they're more likely, if they're cardiovascular, to die of heart attacks. And that's well proven in the epidemiologic literature. So I know we worry about strokes, and people who have had a stroke, it's that sort of, up to kind of 5-year period where they have the increased risk. That decreases after time. They're more likely to die of a heart attack. And the concern is with the disabling stroke, because they have mild strokes and they have transient ischemic strokes. And the way the studies are done, they don't capture that this is a disabling stroke. They just lump them all together. So I'm afraid I'm not able to kind of give you information to say that, if you give a statin, you'll prevent this number of disabling strokes, which is what everybody's worried about. It's important to know that because we'd like to see that, but that evidence just isn't there like that. So there's a lot of limitations. What about in the population? So the lifetime risk for having cardiovascular disease at age 40 to age 95 is 60% in men, 55% in women. That's in general. So anybody sitting in this room, depending what age you're at, realize that, cardiovascular disease is the second leading cause of deaths. Cancers are the highest, but as you age, cardiovascular becomes prominent, and that makes sense. So even if you control all the risk factors, then lifetime risk is still 30%. So I put that up there that it is common. So of course we're concerned. Here's stroke recurrence again, 20% first year. In this type of study, it said 33% by 5 years. But I found something by going through, all the kind of Health Canada and types of information, that the prevalence of stroke and long-term cares, and of course this is sort of an average, is 16% for men and 14% for women. So we are dealing with people with strokes, but it's not all that common in care homes. What's common is dementia. And that heart disease is 3 times as common cause of death in the 85 plus as strokes. So let's talk about something a little more practically related to actually how we would approach people. Now there are prognostic indices and tools, but I think for our people, particularly people with dementia, that we have a more clinical way of looking at that. But we are looking at frailty and dementia trajectory, and on our shared care site, it's sharedcare.com, we have video links where we really have some experienced physicians talk about how they relate to families about the dementia trajectory. And we're starting to learn how to have serious illness conversations better. So here's the frailty scale. I think most people are familiar with that, but I think it's important to recognize that people in care homes are generally severely frail or very severely frail. And they are in that last phase of life. And so that's the context we're working in and reviewing medications. And also stages of dementia. You'll see severe frailty. You'll recognize that the residents we're working with are way over on this side. So if you're actually talking with a family, working to look at the context of a resident and seeing where they're at in here, then that should give you some assurance that you're really looking at the last stage of life, and for many of them a palliative stage, and looking at the medications in that context is really a lot more useful, and being able to be more critical about that, including statins. So with dementia, there was a study that looked at this advanced dementia, 6-month mortality, and this would be like people with the 7s and 8s that we have on the frailty scale. 6-month mortality is 25%. Median survival is 1.3 years. And I don't know exactly what it's in the Victoria area, but I know that the survival, or the time that people live, the mean actually is around 18 months in care homes across British Columbia, and that's been repeated a number of times. And then people say, well, I have people live 3 and 5 years and whatever, and certainly we'll have those people. But by and large, people in care homes are at this type of stage, or getting to this stage, and usually deaths are not predictable so much by an acute event, they're predictable by here. And you've seen this so many times, right? Start developing swallowing and feeding problems, then they'll get the infections, and that tells you that they're entering the sort of the last 6 months palliative phase. And that's really a critical stage for looking at medications. If you have that background of recognizing that we don't actually have a lot of evidence that applies to this population, but we have a lot of experience. We recognize these people are coming in at a sort of moderate to late stage of their conditions, particularly with dementia, that their remaining length of life is going to be, sort of 1.5, some less, 25% will be less than that, 1.5 years, 2 years. And so that's the context we're actually looking at. And so is there some information that might help us to say how effective medications are in this population? And I think that the way we view treatments and drugs, we always think that medications are more effective if we're talking about treating sort of a whole group of patients than what they actually are. And I'll show you this with the statins. Oops. Now this is a bit of a busy slide. I break it out for strokes. But if you look up here, primary prevention is people who have not had a defined cardiovascular event. And this is grouping studies. It's called meta-analysis. It's a technique of grouping studies. So you have more patients, more data, so you can make a little bit more valid assumptions. And over 3.5 years, this, people over 65, because we don't actually have it done in people over 80, especially not the frail people. If you gave a statin, only 1.2% avoided a heart attack, 0.7% avoid a stroke, 98% see no benefit. That's for primary prevention. And it's given here, primary. And we all think that things are so common, but the event rates, and this one is over 3.5 years, is like 4% if you give a placebo over that length of time to have a heart attack in people over 65, and it only goes down to 2.7% with treatment with a statin. And again, we all think that statins are, and other drugs are going to be so effective, and patients are told that, and that's part of our challenge, is to kind of say, well, they're not, even though if you're told that. And so the concept of number needed to treat, how many people you need to treat in order to prevent one event? And so you have to treat 83 people for 3.5 years to prevent one heart attack and 142 to prevent one stroke. That's for people who have not had an event, and you don't actually affect mortality. Whereas if they've had some event, then you have to treat 40 for a heart attack, 50 for a stroke. But it's still, if you look at it from a benefit point of view, then the benefit really, if you're treating 100 people, then you're not going to actually provide a benefit in 92%, and they might be subjected to side effects. Now, I put this up more because we need to have that perspective. You have people coming in on medications, and they could very likely have fallen into one of these categories, and maybe at an earlier age group. And they're coming in thinking that, that the statin would have prevented a heart attack or stroke. Well, they might not have. If they haven't had one, then the statin might not have done anything anyway. If they've had one in the past, a lot of people will have a heart attack or a stroke on a statin. So the statins are not, as many drugs, are not that, really the low percentage of people that benefit. So I think that should help. And so what we've done here is to just break out for the strokes, and we've turned it into a 1-year rate because of the length of time people live. So if people have not had a stroke before, and the annual rate is it's less than 1% of people will have a stroke over the age of 65, and that's the risk difference. And this is just for stroke, pulling it out for a year, because you need to treat more people over a year because the time frames. So it would be 500 people you'd have to treat for primary prevention and 250. So I'm just giving you that idea, the numbers, that you actually have to treat a lot of people because the drugs are not as effective as we think. Now, I will put a caveat on that, because we don't just use statins. We treat blood pressure, we do diet, we do all sorts of things. And that's why we do this whole congregate of things, so that we can actually make the overall more effective. Right. That just shows how those are generated. So then I asked myself, because the studies have been done in people with cardiovascular disease and statins, and if they've had an event, and most of it has been done with people who have had heart attacks, much less with strokes. So that doesn't answer our questions that well. So I said, well, is there at least a study or some evidence that people who had no known history of coronary heart disease, normal cholesterol in this study, and to see whether, and this is high-dose statin, whether it actually prevented recurrence of or stroke recurrence in people. So they actually had no coronary heart disease, but they had a stroke before. And so this is a randomized controlled trial. You see the mean age is 63, so they're not the old for sure. And so there was a significant reduction in fatal stroke only, not in non-fatal strokes. So what this tells me is if we're really trying to pull out the stroke part of it and not deal with the heart part of it, that the statins, we don't know, but they might actually not reduce the number of non-fatal strokes. That's what this study says. And so again, calling into the benefit of statins for this population because we think that we're afraid to stop them because we think a stroke's going to happen. Well, they actually may not be all that effective even in the first place. Then I asked myself, well, what about diabetes? A lot of us have heard that if you start a statin, that some people are susceptible to increased blood sugar, and that might put them into a diabetic state. And that's true, and it seems to be for people who might have been predisposed, sort of that pre-diabetic state. But it did cause a lot of media flurry, caused that some people didn't want to take statins or they went off statins. And so, but really, this is concepts of the number needed to harm. How many people would you treat with a statin in order to put one into sort of a diabetic state? And that's 250 people. So it's not all that common in relation to how many people that might benefit from a statin for diabetes risk control. And as I said, there's people that probably are pre-exposed. And so what the recommendations are is that on balance, if someone is diabetic and has that cardiovascular risk profile, that a statin would be indicated, but recognizing that there still is possibly going to put up their blood sugar. But it's just because the number needed to treat to prevent vascular events is higher than the number needed to harm. And so this is where, if you've heard about that, if you get a concern expressed to you about this aspect of things, statins are still recommended in people with diabetes or that might get into the diabetic state. So then I said, okay, well, what about the actual benefit of statins in people with diabetes? Now, this is low dose statin over 3.9 years. Again, not the old people, and they had diabetes and one other risk factor, and looking at acute coronary. What they tend to do now is to group all these events so that they actually can make a more of a definitive statement about will they prevent any cardiovascular events. Unfortunately, then it's really hard to pull out some of the endpoints that we're looking at. So in this study, for the composite, if you treat over 3.9 years with a low-dose statin in people with diabetes, then you treat 32 to prevent any of those cardiovascular issues. And you may not be familiar with number needed to treat so much, but as you talk to patients, when you start getting closer to around less than 40, 30, that kind of thing, it's generally seen as, well, maybe I'll take my chance. If it's going to help me, maybe I'll be sort of, one of the ones to benefit. But when you're up higher for the stroke, around 78, then maybe it's not as effective as we thought. Again, calling into question whether statins, are they really as effective for stroke as we've been led to believe? Then I asked myself, well, what about statins and heart failure? Now, of course, we know that we want to prevent all the risk factors for heart failure, blood pressure, and heart attacks, that kind of thing. So statins have a place for the heart attack part of it. But statin therapy did not decrease all-cause or cardiovascular mortality, but they did decrease the rate of hospitalizations. So if someone's on a statin and has heart failure, so the implication is that you probably would want to leave them on because you just don't know what it's going to do, depending on their life expectancy, what it's going to do as far as destabilizing them as far as their heart failure. So I found that piece of evidence. But you can't believe how hard it is to find this stuff. It's kind of like you find one study and then you reference to something and you go to it. Like nobody's put it all together, especially not for our population. So what about adverse effects? Well, what happens in the elderly? Well, we know they have a lot of variation in their physiologic age because of frailty, comorbidities, so they don't handle drugs as well. Risk factors for cardiovascular disease do not predict outcomes as well in the elderly. And there's competing causes for mortality and frailty, of course. It's really hard to use the drugs because of the frailty that people have. And the adverse effects of therapies are more severe and predisposed to all sorts of problems that we see in the older person. So with that background, this is from the Therapeutics Initiative. And I know that a lot of people are kind of questioning the way they look at evidence, but I did like the way that they put together the potential harms from statins. So this is if someone's on a statin, if someone's not on a statin. So you might get the muscle aches from statins, might affect the kidneys, the memory. I'll go through that a little bit because some of this is a little questionable. it's not exactly proven, might affect the heart function. Whereas if you don't give them a statin, then the muscle strength is preserved, and all these different areas that statins might affect are preserved. So that's kind of the way they've approached it. Then they broke it down into the highest level of evidence is where they've been able to group studies and do a review. Because by and large, studies are funded by drug companies. They're short-lived. They don't really look that well at side effects, unless they really explicitly say they're going to look at side effects as well. So a lot of people will say, well, we didn't find them in the studies. Well, they actually weren't looked for, or it's a really short period of time. So what they did is to try and group studies so they had a little bit more evidence. So with statins, high dose versus low, the withdrawal due to adverse effects would be in about 2.1% of people. So so in the studies at least, there is some withdrawal. Muscle damage with CK elevated, again, very small number. Liver enzymes. So those kinds of concerns we have, they didn't really find at the highest level of evidence. And again, this is the newly diagnosed diabetes that they found that there really is an association. And this one is going to be real. Now, in single randomized controlled trials, that there was somewhat of an increased risk, although it's less than 1% of hemorrhagic stroke. Now, this is where they couldn't actually get this kind of information because these ones use a scale. But on scales, they found that there is some evidence of decreased cognition affecting energy and fatigue with exertion. And cardiorespiratory fitness is decreased. Sleep quality can be decreased. Again, the diabetes issue. But the proviso here is that this is one study, even though it's a randomized controlled study. And so what you want is to find out whether that's going to be available elsewhere. Well, those studies aren't being done, right? So this is the best evidence we have that, and look at these things. In our population, statins might have these side effects. We just don't know because they're on it. They come in on it. They come in, they have memory impairment. Their energy is not great anyway. That's why they get in. Is it the drug? Is it the combination of drugs? So I think this is what I think we should start asking ourselves because there's some evidence in studies. Oops. And then there's observational studies. And I only put this up because you're going to hear this in the media. Observation studies are not causal. They can't prove it. But if they're big and they've done well, they at least highlight this might be possible. Acute kidney or renal injury, failure, liver problems, muscle, et cetera, and even cataracts. So you might hear about that. So I put this up to say, there may be some implication here. We just don't know, but you might hear about that. And more importantly, that there's drug interactions. And we know certain antibiotics will interact with type of medications because they have common enzyme systems they work with. And that's where I think the pharmacist is really, really integral to actually helping us looking at these medication combinations that have these interactions that we might not be familiar with. Because they might actually develop a problem from a medication, and then we give them another medication because of the problem. We don't recognize it's that caused by another drug, and that's called the drug cascade. So there is some issue with that with statins as well. And if you actually look at the listing, you go on what the lay people will read, you'll get this list. And some of this is only, as I say, because they've done some observational studies. But this is a list of different side effects that you might expect with statins. Not common, but the most common. So I put this slide up because I think that, doing this work over the last couple of years, certainly I've looked at adverse effects and falls and all the major things and deliriums, and we look for that. But I am really convinced that medications are contributing to making people feel crappy. Because they come in on all those meds, and we say, well, that's what Mrs. Smith is like, right? And we're going to keep them on the meds, or we might make some adjustments and whatever. But I ask myself now, because these medications, if you have some nausea from one medication, and we're younger, we kind of tolerate it, and maybe it'll go away, and that kind of thing. But if you have nausea with 5 medications, so 5 times a little bit becomes not just a little bit. So, and it might be muscle aches, it might be constipation. So that's the way I think we have to start changing our thinking. These minor side effects, I think, are more important day to day than some of the major things we look for all the time. So the last concept is time to benefit or time to lose benefit. Time to benefit is looking at how long do you actually give a medication before it actually has the outcome that you want it to have, and time to lose benefit would be the reverse. Well, there have not been studies done on time to lose benefit, so we kind of say, well, what's the time to benefit? And if we withdraw the drug, then is it going to take the 5 months or the 6 months or the year for it to lose its benefit and cause a negative outcome? So I paraphrased, in the province, sort of 1 point remaining life expectancy, 18 months on average. There was an MRI study that looked at regression of plaques and plaque stabilization by given statins, and it was 12 months by the time the plaque was actually stabilized. And so, would it take that length of time as you withdraw statins for the plaque to start to break, become unstable, therefore cause a cardiovascular event? I mean, we don't know, but we try and look at it this way. And for stroke, benefit may start at 4 months, but statistically significant at 12 months for survival and functional outcomes. So there was a study about that. So it seems to take longer, it takes a while for a statin to take effect. So maybe if we're stopping it, maybe it's going to take a while for it to lose its effect. And then for people who actually don't continue it, after an acute event, it can lead to negative outcomes. But for longer term use, and bringing people off that are not in an acute stage, it seems like we should have some actual time to actually withdraw the medications. Not expect, and I hear all the time, well, if I take them off, and some anecdotal people say, I took this person off a statin, they had a stroke the next week. Well, I don't really think it's due to the statin. Not with the evidence that I've found. Of course, it's concerning, and you'd want to be talking with a family and saying, this is why we're doing it, and paraphrase the evidence as best you can. But from what I've been able to find, and this is what Ian tasked me with, is to say, can you find something that's going to assure us a little bit more that if we actually start withdrawing these medications, we're not going to get into these sort of shorter term problems? And this is what I found. It doesn't seem like it. And here's a couple of studies. Oops. So one of the things is dosing. I know we talk about deprescribing, but cutting down doses and lowest sort of maintenance dose is a principle of geriatrics that I think we should be applying more systematically, and particularly for blood pressure medications and for statins. If we're going to continue those medications, then really look at the lowest dose you think that might be effective. So I put that slide up for that. So there was a study that was done. Unfortunately, this was a discontinuation study. And in this one, they had a washout period. And so a lot of the statin studies actually had that. Well, a washout period is when you actually stop the drug so you can actually start de novo. And part of the reason they do that is to kind of find out who was having problems with the statins, and then they don't put them in the study because they don't want people in the study to have problems. But anyway, that's another issue. But so they found out that yeah, you do start to get some inflammation soon on, but when you actually treat it, and there's a 6-week washout period in stable cardiac patients, that it didn't lead to a clinically important significant vascular events. So this is kind of a way of getting at it through the back door, because they stopped the statin for 6 weeks and they didn't get an increase in vascular events. So that's one piece of evidence. And this was an actual discontinuation study. These were people that had life expectancy between 1 month and 1 year and no recent cardiovascular, but there's 50% malignancy, and so not exactly our population, but it's the only study we have. And the people, there was no difference in mortality at 60 days. Quality of life was improved in the group that was taken off statins. So this is the only study we actually have that looked at it this way. So they didn't die more frequently, and the quality of life, which kind of implies that, and they had fewer cardiovascular events. They actually had fewer. And how do you explain that? Or few experienced cardiovascular events, I mean. So, so they thought that I mean, there are some criticisms about the study, like everything, but this is the only study that I could find that actually that looked at it in this systematic way. And then there's a smaller study in a nursing home, but it was only 10 residents, but they evaluated for things important to us: falls, muscle testing, whatever. None of them had a cardiovascular event, although it didn't make a difference in some of these other things. But you know, the way that study is done, we can't make a lot of inferences. But the important thing is that they tried it, and they monitored it, and they didn't have cardiovascular events with those patients. So I found that as well. So I'm not going to tell you what I think you should do, because it's a conversation. It starts with goals of care. It starts with understanding the resident and the disease trajectory. And that's why we've changed our resources to calling You Decide. We try and give the evidence. We give some of this information, and then we say it's best that you actually, resident by resident, have those discussions. So let's look at a couple cases quickly. So this is, and I've used this just sort of as a stem, 84-year-old woman admitted to your care home, inability to live at home, moderate dementia, and on following meds, but no goals of care have been identified. So you see a moderate dose statin, but she's had high cholesterol for 10 years, no cardiovascular history, blood pressure, thyroid, and some PRN pain control. And so I sort of made this thing up. So what would you do in this situation? Would you no change? And how confident are you just to leave the medication the way it is? Would you do a dosage reduction? Would you do a discontinuation? Given this scenario, and I know people are all a little bit different how they approach it, and there's no exact right answer. It's how you think through it. Yes.
Well, it brings me to some questions about what you said before, because I noticed that you've made no difference between genders. And as far as I know, in any age group, statins make no difference in primary prevention in women. So I don't know why it would make any difference in primary prevention in an elderly person. That's one comment. The other thing that's interesting to me is, in the absence of evidence, isn't it interesting that we're pitching from this from the point of view, is it okay to take it away? Surely in the absence of evidence, the question we should be asking ourselves is it okay for us to offer this medication?
Exactly.
Sure, they happen to be on it, but it seems to me that why are we offering this person this medication when there's no evidence to show benefit, even if she were younger?
Her type, yeah. So two things. You know, I didn't put the gender thing up specifically because I hoped I'd get a question. It seems that if the cardiovascular risk of a woman
is the same as the men in the studies, this is what they're saying, then the sort of risk reduction through statins is actually the same. It's just that even in primary, yeah. Now, but it's debatable, and I've read all these debates, right? You have cardiologists debate this sort of thing, and they parse the evidence, and they criticize the studies, and all sorts of things. So I think it's unanswered. The second thing, well, of course we know we have to work upstream, right? Before they get into care homes, because it's not that we're starting statins necessarily in a care home, unless they go to hospital and they've had a stroke or an MI and they come back on it. And that's acute, and that kind of thing. And we know the number to treat falls way down to like 30 or 40 or something like that. So, okay. But yes, so for the physicians in the office, we do residential, but really you go back to your practices, and I hope you take these things back. And I know they're prescribed by other people, but having those discussions, that's where it needs to happen. Okay? So I know in a group it's really hard for people to kind of commit and put up their hands and say, I do this, I do that, because they don't want to. But I just put this up for your own self-reflection, really, unless someone wants to make a point about what they might do. Because I have a few other cases as well. Because I know it's hard to call upon people in a setting unless we're doing a very small group thing.
I'd say give it a try. All those people who would stop the atorvastatin 40, put up your hand.
that's down there. Okay, that's a lot of people, yeah.
Thanks.
Good.
That's at least half.
Yeah, and I think that's where things are moving to because of primary prevention. She doesn't have that,
Type of problem. So what about if her goal of care was to go to her granddaughter's wedding in 1 year?
You know, that will cause you to think a little bit more, right? Now, I know the people that are really convinced that they could stop the statin have the conversation and said, you know, when you started it, for your type of person, really the benefit of it was very low anyway. And if we stop it, you know, we think that we would be able to stop. And you have to sort of figure out how you're going to say that. And so for a fair number of people, that they would still stop it. So let's do the thing. So how many people would just go to the discontinuation?
Yeah,
Yeah.
you have to remember, in our patient population, quite often, we're not treating the patients, we're treating the...
Oh, I know that, yeah. Well, that's why I'm saying the goals of care discussion,
Yeah.
the goals of care discussion is with the family, but you still try and find out what the person would have wanted before, right? And so it's that sort of balancing act doing it. And I've done it with family members, and it's not easy, because you're not just dealing with one person in the family, you're dealing with lots of people. And to be fair to families, we have to provide them with enough information so that they can make what they feel is an informed decision. Apart from all the emotional things, part of it. But you're right. Yeah.
There is a perception in the general public that we may not really care about the elderly. And so family members kind of counter that perception. So you really have to work diligently, especially if you have multiple children. And then you have multiple,
And it's hard at the point of admission, but that's where that conversation starts. Because you don't want to start pulling a whole bunch of things there because they don't know you. You know, once they get to know you and realize how supportive the care homes, but the care homes are now starting to ask right off the bat, you know, what did your loved one do? What kind of work? What were their interests? We're really going to try and, you know, work for their quality of life and what they would like to be doing given where they're at now. Start having those discussions, they start to trust you, that you're not actually there just to house them and hope that they, you know, don't whatever sort of thing. So.
I'm an RN in one of the facilities, and one of the big problems that we have is the physicians don't follow into the facility. And so we get a patient and their family who had trust in their previous physician.
And it's taken over.
They come in the door and there's a new person.
physician.
They don't know us, the nursing staff, they don't know the doctor, and then it takes longer to build that trust and have these conversations. So that's another barrier.
Yeah. I think certain medications which are emotive, like, you know, the cognitive enhancers for dementia, drugs that people think are going to stop stroke, things like that, to preventive medications, it is harder. And you're probably not going to do that right away, trying to establish that trust and stuff like that. Yeah, and the new doctor is a challenge, but actually has to somehow get involved. We recognize that. So anyway, how many people would discontinue the statin in this scenario? A few less, a few more gingerly raised hands. Okay. All right.
I wanted to know what sort of numbers you would be starting to use when you're having a conversation with the family. Are you ready to start saying, oh, you know, it's a 1% chance that what I'm going to do is going to have a heart attack and a very, very small percent chance it's going to cause a stroke? Yeah. Do you feel comfortable with numbers now that you've done the research?
Well, I mean, I start off with their understanding of the health, you know, where the person's at with their health and declining in health and their life expectancy and all that kind of thing. So to get that perception. And the next area is to say, what's your understanding about the benefit of this type of medication, given your mother's situation, before I throw any numbers out.
Okay.
And then if they're amenable to numbers, I say, well, did you know that, you know, it really only benefits about, you know, less than 1% of people in your mom's situation, even at the start. So, you know, and sort of go that route, right?
Okay.
Okay. All right. I know that Ian's going to yank me soon, but I've got a couple minutes. So here's a little bit different. Someone who comes into the care home has had 2 disabling strokes about 2 years ago. They recognized that she was on a statin at that point in time when she had those strokes. And not demented, on these meds. The goal of care. So if the goal of care, she says, you know, I've had the strokes, I'm not getting around that well, I got the ache, pain here, et cetera, I don't have family, whatever it happens to be, and, you know, I really want to make sure I'm comfortable, and if I have any symptoms, control that, but I'm not here to live a long time. I might not say it exactly like that, and that would be one scenario. And the other scenario with someone who is secondary prevention would be more around, well, I do want to be around for a while, right? So in this first scenario, they've had the secondary prevention, recognizing what I said the numbers
needs to treat, and the benefit is sort of thing. But it gets more difficult. That's why I put this up. Not demented, so able to actually participate. But she's saying this. So again, we'll cut to the chase. In this scenario, you'll obviously have to do a fair amount of discussion. But how many people, if the patient really is not tied to this medication and really just wants to minimize medications, how many people would discontinue the statin?
Yeah, a fair number of people as well. That's right.
I would ask if she was on the atorvastatin when she had the 2 strokes.
Well, she was, because this has been on for 10 years.
Well, no, it doesn't say, it just said hypercholesterolemia.
Oh, well, that would be the case.
But I think if she had the 2 strokes while on the atorvastatin,
In this
I would
case
say,
scenario,
I would say, well, this is highly unlikely that it did any good whatsoever.
But, whatsoever. I'd say something like that, yes.
The other thing is, didn't you say something about how it didn't, like it, the fatal versus the non-fatal strokes, and maybe a lot of the patients in the hospital say they're ready to die, and so maybe she has like a better chance of a fatal stroke? Maybe, I know that sounds bleak, but maybe.
No, not bleak. It is a harder discussion, because do you initiate that as a care provider? Again, I'll refer to my family situation. We would have preferred, as would my father have preferred, to die in hospital and not go to care, be on an antipsychotic. We took him off all medications. And knowing that he would have preferred to have had a fatal stroke. And if he has a fatal stroke in care home, or even another one that's going to sort of get him onto that slippery slope faster, then that's what he would have wanted. But those are hard kinds of discussions to have. So I don't know if people have experience. Maybe a family member will bring that forward, but you have to make sure everybody in the family is on board with that. They were in my family because we did a lot of work around that. But it is a difficult discussion. But you're right. I think a lot of people have that in the back of their mind. Dad would not want to be like this.
I think it would be interesting too if this person's interested in symptom control to say, I don't know whether they would notice or their family members to say, why don't we try stopping the statin for 2 weeks or a month or whatever you choose, and you observe, does mom or dad, mom in this case, does mom actually feel better?
Exactly.
Is she having side effects that have been subtle and unrecognized? Because that will help us go one way or the other.
Yeah, I think that's a very important point, because you turn it into a positive,
Right? It's that we're not giving up.
Benefit.
Yeah, we're not giving up. There might be a benefit to stopping this, and we're going to monitor, and let's see whether there's a benefit. So you've turned it into a positive. And a case, I have a polypharmacy case, if we have time in the end, which actually puts that into that kind of context sort of thing. And going to the granddaughter's wedding in a year, more difficult. We kind of say, well, especially if she was on the statin, which is the way I kind of set it up, and she's had strokes on it, we don't think the statin's really going to work. I think it's just a more complex discussion. If you're able to have that discussion, how many people would stop the statin even in this scenario? Yeah, so some would. But again, the challenge of actually having that type of discussion. So put that up for there. All right, last one. So this is a person who's been living in the care home. Now the strokes are 4 years ago, severe dementia. And both care here, for sure, symptom control, quality of life, and a low dose statin. And I think I put that up not because it's a hard answer, because I think most people would discontinue. We'll see what you want to do, but it's just that this is what you should expect. People are going to progress this way. I mean, this is what happens to our residents. So that if you're hesitant early on, or if there's some other issues, or the family, all that kind of stuff, in your mind you should be realizing that at this point in time you're very likely to then really be a little more assertive. Well, not assertive is not the right word, but really more supportive of trying to get off the statin as well, sort of thing. So discontinuing statin with this kind of scenario, how many people would do it at that phase of time? Yeah, there we go. Okay. So you see the sort of the benefit. It gives you a bit of an idea, and if you're able to, I think I put the numbers up because I think it helps us, right? It gives us a little more assurance about having those conversations. And if a family, certainly in the office, if a patient's amenable to numbers to help the discussion, but you just don't use numbers. You actually have to set it in that whole context of things. So this is how I think, And that's why I said you decide, because you actually, each scenario is different. And you did decide. So great, thank you.
Thank you very much, Chris.